You're over now.
Hi, good afternoon everyone, and a very warm welcome to our CQC webinar. My name is Kate Terroni and I'm the Chief Inspector of Adult Social Care, and I am going to be talking to you over the next hour. For any of you who have done these team live events, they're very odd, as in you only see a couple of your colleagues at the bottom of the screen and you have no sense of who else is out there, who's listening, how what you're saying is being received or is landing, because you don't have the kind of cues of looking at an audience. So I would really invite you and encourage you to just keep a chat going with me. I've got the chat box open, so if you want to just say hi and where you're from, or if you want to react to things as I go or ask questions or put your comments in, I will keep them open, and I will endeavour to do the double act of talking, sticking as best as I can to the slides I've got in front of me, but also seeing what you're saying on the chat function. So please say hello, let me know you're there, and chat away as we go. So really pleased to have you join us. The purpose of this webinar for the next hour is to talk about us at CQC, what we've been doing recently, what we're going to be doing next, and what we're going to be doing in the future. And that's going to kind of cover two strands. One is about how we are transforming the way we work operationally, so different ways of delivering our business, and then alongside that, how we are transforming for our future strategy. So that's what I plan to cover today. I'm just going to let you know who's on the call. So if we can go to the next slide, please, Steph, when you're ready. Now, I can't yet see any chat on the call. Oh, there we go. Oh, hello. A few people saying hello. Lovely. OK, that's good to see. Great. Dorset, North East, Orchard Trust, Portsmouth, fabulous. OK, so I'm Kate. I've got Debbie Ivanova, who's my Deputy Chief Inspector, on the call, who will be helping me answer some questions. And then we've got Sarah, Sam and Steph looking at your comments, and they will be driving the slide deck. So that's who's on the call today. So what we're going to cover is I'm going to briefly remind you of our role and purpose, going to talk a bit about the timeline and what we've been doing so far in adult social care. Going to focus on infection prevention control, winter, care at home and our pilot that we're doing, and talk a bit about our transitional approach. And then we're going to have a break to have some questions, and then we're going to get on to the strategy. So that's the plan for the hour. Oh, and some nice, thank you, Claire, nice to see you too. All lots of lovely comments, so I'm not talking to myself. Wonderful. OK, so before we get into our purpose and what we're going to cover today, I just wanted to start off by acknowledging where we are at this moment in time. So I think for many people, 2020 has been one of the most toughest years. And I think for people in social care, for people personally, for people with their families, it's been really grotty, with bereavements, with working in a scenario you never probably envisioned you'd be working in. And then we got the news on Saturday night that we all knew was coming, but still doesn't make it any easier to hear. So I just wanted to start off by saying I don't know how you felt when you woke up this morning, but you're probably not on your own if it felt a little bit harder to get out of bed, a bit darker, a bit tougher as we think about the next 4, 6, 8 weeks, and as we kind of cling on to spring and brighter days the other side of Christmas. So I just wanted to share with you that you're not on your own if this morning felt a bit tough getting out of bed. It might have felt like that quite a lot over the last 8 months, and just to say, hats off to you out there doing what you do, and keeping people safe and delivering high quality care. So just an acknowledgement that it's really tough, and thank you very much for all that you do. And just to address a couple of quick things that we'll get into a bit more as we go, is with the announcement on Saturday, we've already had quite a few queries into us about what does this mean for inspections? Are your staff still going out and about? And we absolutely will be. So I will cover during this slot a bit about how we did things differently during the first wave, but how our intention is absolutely to keep on crossing the threshold during wave 2. And also I'm going to talk to you a bit about what we said already around visiting, because it's as important as it's been to ensure that you were all doing that really tough job of weighing up keeping people safe while supporting people to see their loved ones. So just wanted to do that as a bit of preamble. And one other thing before I get into the slides is we've done one of these webinars before. We did one about 2 weeks ago, and I asked for feedback at the end about was it a good use of an hour of your time? Did you get from it what you needed? And we broadly had positive feedback, but I do want to acknowledge the main negative feedback we got was that the people on the call felt that it was quite care homes heavy in what I was talking about. And I haven't changed the content of these slides for this. So if you're not in the care home business, I just want to give you a warning that that might be your experience. And I just want to explain why we are still going to be talking about care homes at the start of this presentation. And that is predominantly to do with where we have found the greatest risk around COVID. So quite a lot of focus has been on care homes, but that's not to say we haven't continued to keep an eye and engage with the rest of the sector. But I just wanted to give you a little heads up that we've listened to feedback from the last group that said you talked a bit too much about care homes, and I just want to acknowledge I'm going to do that again because that has been where the risk and some of quite a lot of our focus has been over the last 8 months. But that's not to say if you're a supported living provider, shared lives, extra care housing, home care, hopefully we've got something that's of use to you as well as we go. Okay, let's dive on, please, Steph. So I won't hammer this point because you will know it well and good. So we are CQC, we're the independent regulator of health and social care in England, and our job is to make sure that people are getting high quality, effective person-centred care. So that's what we do. That's great to see. We've got some staff nurses on the call as well. Wonderful. Great. And we're doing better this time. We had some people who we think were meant for the hospitals webinar join us, but you're looking at your all social care, which is fab. So our purpose as the regulator is not changing, but we need to change the way we do business so that we can make sure we remain relevant to all the people out there who use CQC as an indicator about what the quality is of people, of services that are being provided. So we need to ensure that we can continue to pay all the attention we need to the voices of people who access services about their experiences of safety and quality. We want to do better at giving providers real-time information about how they're doing, and the public. So if you're looking for what CQC says about social care providers in your area, we want to give a much more up-to-date view of that. And we want to give information to providers where you can look and see that, you know, one of the social care providers down the road has just got an outstanding rating or has just got a good, what is it that they're doing that you want to learn from as well. And we want to continue to focus even more so around improvement, how we can work together to improve the quality of services. So that's what we're all about. And then I'm going to just give you a bit of a timeline. So we started thinking about what our new strategy should be a little over a year ago. So our current strategy finishes in April, May of 2021, so next year. And almost over a year ago, we started thinking about what our direction of travel should be. And actually what's happened is our thinking about how we can provide much more real-time information for people about the quality of care, how we can do more, place more emphasis on improvement, how we can have a more flexible way of working. Actually, what ended up happening through the pandemic is our plans for the new strategy and the way of working ended up being brought forward, and we ended up implementing a whole host of things in keeping with where we think we're going as an organisation, but a lot quicker than any of us probably thought we could do prior to the pandemic. So we rolled out our emergency support framework in May. We are implementing a new transitional approach to regulation that we're doing now. We've developed an approach around infection prevention control as we speak, and we are testing out our strategic themes. So that's what we're doing here today. And then looking forward, we are going to carry this conversation on for the next month or so, and then we'll have a formal consultation in the new year in January, ready for it to go live in May 2021. So that's where we are in terms of timeline. You want to move us on? Okay. Oh, so many people saying hello. I must not get myself distracted. Oh, we've got skills for care here. Fab. Okay, so quick recap about the emergency support framework. So you will all remember that at the very start of the pandemic, we made the decision to pause routine inspections, and that was at the time when none of us really knew what we were dealing with in terms of the disease. We were very conscious that it needed to be all hands on deck from provider perspective, and actually the only thing we wanted to do in those early weeks and months of the pandemic was to support you in coping with something that none of us have had to cope with before. So we said we were going to pause routine inspections, but that we were always going to go out and cross the threshold where we needed to in person. And then we busily set about having lots of phone conversations with many providers, but we also developed this emergency support framework, which is a set of questions, and I'd be interested to hear from you how you found them. We introduced a set of questions where our inspectors could talk to you with an emphasis about a supportive discussion, enabling us to get support to you, so we were able to escalate issues to government and locally to things like local resilience forums, when in those early days you were telling us loudly and clearly about issues around access to PPE, access to testing, and challenges with staff isolating at home because it wasn't known whether they had COVID or not. So we developed our ESF, we had structured supportive conversations with you, and we used it to hopefully get you the support that you needed when that was being flagged up to us. And then we used all of that knowledge we learned from our emergency support framework into this new transitional regulatory approach, which again is a kind of structured way of having a monitoring conversation with you all, but it's a bit broader. ESF started off very narrow, and our transitional regulatory approach is a bit broader in what we cover. So let's move on, Steph. Okay, just a few numbers to let you know what we've been up to. So we have done ESF, Emergency Support Framework, on over 17,000 locations, and that equates to about 70% of active social care locations have had some sort of regulatory intervention, and that's either an emergency support framework or that's an infection prevention control inspection. And you'll see in the bar chart the number of physical inspections we've done increasing notably since about July time. So we've done a total of just under 1,500 inspections. That will probably be slightly higher because these figures are a few days out of date now. So that's what we've done so far. If you want to move on. Okay. So where we are now is we're evolving our approach. We've developed a new approach to infection prevention control that I want to talk to you about. We've got our transitional regulatory approach that develops all the stuff we learned around ESF, and all of this learning is going into our future strategy. So let's move on and talk a bit about IPC, infection prevention control. So in August, we developed we've always looked at IPC, but we developed a new methodology that was just infection prevention control focused. And we had a couple of main drivers for this. One, we all know that IPC, good IPC, was one of our main defences against keeping people safe from COVID. So we were really keen to not just go out to risky services to look at IPC, but we wanted to see what best practice was as well. So we undertook a little over 400 IPC inspections in the late summer. About 301 of those were going out to good services to look at what they were doing well across 8 areas of assurance, so around things like PPE, policies, approach to enabling safe visiting to happen, etc. And our plans are to continue to do IPC inspections. So we've committed to do 500 from about a week ago through to the end of November. And those are, again, going out to good services, going out to services where we've had concerns from members of the public, people who use services or staff about IPC practice. And regardless of the type of service it is, if we're getting concerns about IPC, because of the level of risk at the moment, we are likely to send an inspector out to go and have a look at what's going on. But also we are working with the government around implementing their winter plan. So you might have seen some of these announcements, or you might be contributing to this, but in following the work of the task force over the summer, in the government's winter plan, they talked about supporting people who have a COVID positive test at the point they need to be discharged from hospital, not moving back into a care home directly, but actually going to a designated care home where it's been identified as such, and we have gone out and undertaken a IPC inspection with an increased focus on whether that care home can safely cohort or zone those residents with positive COVID test results so that they don't pass COVID on to other residents as well. So our IPC focus will absolutely continue, particularly in the next few weeks and months, but that will continue on, I suspect, for through spring, and we're doing some particular work around the government's designation scheme that I can talk a bit more about if that's of interest to those of you on the call. And finally, we will share our examples of best practice in our November Insights report. So we've been publishing some monthly reports about what we've been seeing as the impact of COVID across health and social care, and we will be having a focus on what we've seen around good IPC in November, with the hope that we can share best practice and everyone has the ability to provide that high quality IPC. So if we just move on, I'm just going to show you what our IPC looks like. So we'll go out, we'll do an IPC inspection. It will be written up, but to make things even easier for members of the public, we've produced a bit of a dashboard that you can see in front of you. So there are 8 areas we look at when we go out and do IPC inspections, and we look at whether we're assured, somewhat assured or not assured on our inspection visit. Somewhat assured often means that there's a relatively small tweak that a provider needs to make to get that into the assured space. If we're not assured, depending on how concerned we are, we might go back and do a fuller inspection as well. But our 8 ticks of IPC assurance is what you and the public will be looking for, and this is what we'll be continuing to do when we go out and do IPC inspections. So let's move on. So this is what we've seen on our IPC inspection so far. You'll note that the areas that need the most amount of focus is about ensuring that people have good up-to-date IPC policies. So I'm sure you have, but if you haven't, this would be a prompt to have a look at that now. And also effective PPE. So we've noticed a bit of a deterioration in the consistent effective use of PPE in all services. So just to plug what you already know, but that's what we've seen when we've gone out on our IPC inspections. So let's move on. So I just want to take this opportunity, I said it at the beginning, but I'm reading your feedback as we go as well. I'm not doing it quite justice, but I will have a proper read at the end also. But you know, it's really tough at the moment, and I hope you feel that we're all in this together, and we will do our best to support you and to encourage you to share your best practice with others as well. And just a massive thank you to all of you and your staff who, you know, when the country was shutting down and is shutting down again, will continue to leave their houses and go into people's homes, delivering home care and into supported living services and into care homes. So just a massive thank you from me. If we can move on, please, Steph. So just a couple of other bits and bobs. In the beginning of lockdown, when we weren't crossing the threshold quite so frequently, it became even more important for us to hear directly from people who were using services about the quality of that care. So we, along with Healthwatch England and about 10 other partner organisations, launched a campaign in the summer called Because We All Care. And we did this because there was some research that showed that since the pandemic, more people were wanting to improve the quality of their local health and social care through giving feedback. So we wanted to really move it away from feedback being something you do when you're unhappy or you've had a particularly good or bad experience, to feedback being something that's much more part of, you visit your GP or your dentist and you give CQC feedback on your experiences, be that mixed, good or bad. So we launched this big campaign, absolutely delighted with the response in terms of the amount of feedback we have received. And just to let you all know that about, I don't have the most up-to-date figure in front of me, but something like 50% of our physical inspections that we've done so far have been informed by feedback we've had from people who use services, their families or members of staff. So this, when people take the time to feedback, it doesn't just go into a black hole. It absolutely becomes part of the intelligence dashboard that our inspectors look at daily when they're making decisions about who to have contact with and where to go out and inspect. So just a bit of a plug for our Because We All Care campaign. If we can move on, please. So to talk about something other than care homes, thank you so much for being patient if you're not a care home provider on this call. We have also used this, as I'm sure you have in your business, as an opportunity to try different ways of working. And we were really reflecting on how much intelligence we could get about the quality of care being provided without physically visiting a service. So, you know, when we weren't crossing the threshold and visiting as frequently, you know, how were we using local health watch information? How were we using information from advocacy organisations, information from local authorities, clinical commissioning groups, etc., to help us have the most up-to-date view of quality and of risk? And it got us thinking about home care, and we had some conversations with UK HCA, so Jane Townsend, and Colin, about whether we wanted to pilot a different way of inspecting home care providers. And I've been out on home care inspections where we visit a service. We often sit in a relatively small office in some business park. We speak to a couple of members of staff, often in a very small space. And actually this pilot is about exploring what would it look like if we didn't spend that time travelling to a registered office, but actually we spent more of that time speaking over Zoom, over Skype, over Teams with people who use services, with staff who maybe aren't on site, they're maybe at home or in another environment, to gather that intelligence about the quality of care. So that's the thing we're testing, is can we get enough information about the quality of a service to undertake a home care inspection without physically going to visit the service in person. So that was what we were testing, and we're in the middle of it at the moment. So we were delighted when 180 home care providers expressed an interest in being part of it. It was always going to be voluntary because we're trying out a new way of doing things. It involves 60 providers that are good or outstanding, dotted across the country, and things are underway now. So we have inspections that are happening as we speak. The pilot will run till the end of November, and we will evaluate that, and then we'll make a decision about what happens next. But if you have a view on it, if you want to share your experiences, if you've been involved, love to see some comments from you in the chat on that as well. So that's a little bit about our home care pilot. If we could move on, that would be great. Okay, so how we regulate during the pandemic. So we are going to continue monitoring, as I've said, and our monitoring will continue to be based on our CLOEs, on our key lines of inquiry. When we go out and physically visit you, when we cross the threshold and come and visit your home care service, your shared life service, extra care, residential nursing homes, etc., your experience will be, I hope, of us being much more focused and targeted in our inspection. And as a result of it, that will lead to a much shorter report as well. We're going to continue to adapt this as we go, and we will be thinking about how the learning from this will inform our longer term way of regulating. Next slide, please, Seth. So, as I said, our ESF, our emergency support framework, is based on our key lines of inquiry. We've got a strong focus around safety and areas such as IPC, as I've said. We're using all these different information to inform how we should work going forward. So our piloting around home care, we're doing some provider collaboration reviews where we've gone out originally to 11 parts of the country to interview providers about what worked well and how they came together during the first wave of the pandemic to prioritise collectively, to move resources around, etc., to respond to risk, and what were the barriers. And we published our findings on that. We will continue to place a strong emphasis on support. So again, really welcome your comments. I know in the beginning I heard really strongly from providers that they welcome the increased emphasis on it feeling like a supportive relationship with their inspector. Really keen to hear whether that's what is still your experience now. So emphasis on support, and obviously using risk to help us make decisions about when we go out to cross the threshold. So that's how we're continuing to develop our approach. Let's move on. And risk is our main driver, as you'd expect. Risk and then a component of looking at best practice as well. So whereas before the pandemic, our frequency of going out and inspect was largely driven by what a provider's previous rating was. We have moved away from that, moved away from our fixed timetable of inspection, and moved away from the previous rating driving our frequency. We want to move much towards, this was our original thinking about our new strategy, how incoming intelligence, how what we hear from people who use care, what we hear from other organisations on a daily basis helps inform our view of risk, and therefore when we go out and visit a service. Inspections in person will continue to be an invaluable tool as we go forward, and we know that's something that really matters to some members of the public as well. You want to move us on, Steph? And then with regard to ratings. So because we're not going out and doing full comprehensive inspections, because the way we're working is very different and responding to risk, we will be really focused when we interact with you, either be that through a monitoring call, be that through an IPC inspection, or through a targeted or focus inspection. We have the ability to look at all of our key lines of inquiry on inspection, and we have the ability to re-rate, but that is not our main driver at the moment. Our main driver is responding to risk. So re-rating is still something that we can do, but that's not our main purpose for going out and visiting a service. Let's move on, Steph. Okay, so I'm gonna pause for a minute, and then Sam, I see Debbie's been busily trying to respond to some of your questions. Sam is going to just give me a summary of some of the things that you've been talking about in the chat, and Debbie's going to endeavour to respond to some of those. So I'll pause for a minute and hand over to you, please, Sam.
Thanks, Kate, and thanks everyone for your questions so far. There's some really interesting ones in the chat. We've had quite a few around the topic of testing coming in, and there's a few key themes there it might be interesting to pick up. So one of them is about what support we can offer to make the case for more testing to be available for home care or domiciliary care services and the staff who work there. And then there's also some other questions just asking us to clarify what our position is for the testing of other health and social care staff who might be visiting services. So, for example, community nurses or GPs, etc. So I don't know if you want to say a bit about that.
Sure, I'm happy to do that. Okay, so we've been involved in the testing discussions right from the beginning and have continued to put forward the need for all care staff working both in supported living, in extra care housing, and eventually moving into also domiciliary care, that testing would be useful. I mean, it is an interesting situation because we actually don't have testing of hospital staff on a routine basis. So adult social care has been dealt with quite differently through this period, but we're already beginning to see what a difference that can make. So yes, we have regular conversations with the department about this, and I understand that the plans as we go forward will be to gradually extend to all parts of the sector. And that also includes the visiting professionals. We clearly at the moment don't meet the criteria as our inspectors for testing because we don't have that regular contact and the personal care element. So we don't fall into it at the moment. But again, that's another issue that we are continuing to talk about with the department, because testing is clearly really important for people to understand how to manage their service and the infection prevention and control within it.
Thanks, Debbie. We've also got quite a few questions about our approach to inspecting and rating during the transitional period. I think just first off, just asking for a bit of clarity about what our approach will be during the recently announced lockdown period, but also I think some concerns around where some providers might benefit from a rating, but because we don't have immediate concerns, may not get an inspection and have the ability to be re-rated?
Yes, this is a tricky one, and I saw there were lots and lots of questions around this. There will be occasions when a rating may change on one of our inspections, because I also saw, I think, a question there about if we found some problems, what would we do? So we could extend an Ipc inspection to become a focused inspection, which has got the ability to change a rating. What we're also looking at is, if there is a real need in an area of the country, and we think that we've seen some really good evidence that a service perhaps that's inadequate has improved, we may be able to go out and have a look at that service and see if we can change the rating. So it's not there will not be changes in rating, but what we have to be really clear about is that isn't our focus. Our focus has to be on looking at what the situation is within the service at this time, particularly where there are risks, or particularly around infection prevention and control. I know that's hard, and I know it means that the chances are that nobody is going to be getting an outstanding rating over the next few months, and some of you have worked incredibly hard to get yourselves into a position where you are ready for that, and we're sorry too, because we love going out and having a really good look at services that have done so much to make a great life for people living in it. But really, we have to think about how we use our resources and how we support in the best way we can the sector to get through this next period of time, and that does have to be at the moment looking at risk and looking at infection prevention control.
Thanks, Debbie. We've got a question here about our Ipc inspections and whether they'll apply to domiciliary care services.
At the moment they don't. It is just about care homes. But one of the things that I've been talking to people about is, actually these are really good inspections, and I think they're really helpful for people. What's difficult about them being for domiciliary care is because they're very much observation of how how people are using infection prevention and control in a care home. Now, that's obviously very different in someone's own home, but there are situations when I can imagine it could be really helpful. For example, if we've got a setting that's being used as step-down beds from hospital, say, people are getting personal care delivery through into that setting, it may be that's appropriate to look at it. At the moment, though, because we've got plenty to do with just the home care with care homes, we're not looking to extend it. The methodology that's on our website, though, could be an interesting and useful thing for people to have a look at, to see the kind of things that we're looking at, because that may help improve practice. And also just to say that we're about to release a new independent voice product over the next, I think it's the middle of next month, which will put all the findings from our infection prevention and control inspections together, and that tells some amazing stories. And I've had some great conversations with people who've been able to talk about some of the really innovative practice that they've done in their care homes, about the ways they've worked with families, and the way they've kept everybody really involved with what's happening. So there's some great stuff out there that people can use the learning across into different settings.
Okay, thanks, Debbie. We've also got a question reflecting on the winter plan and the question of staff moving across services and working in different services, and just asking for a bit more on what our position is on that.
Okay, this is a tricky one, because we haven't yet got the regulation, so we don't know exactly what it's going to be saying, and therefore I can't tell you exactly what we're going to be doing with it. But I suppose what I'd like to reassure you about is this is all based on how important it is that we have staff not in work when they're unwell, when they're isolating. We all know that. Everyone accepts that. It's also about how important it is that staff aren't going from one place to another because of the difficulties with asymptomatic staff and not always being clear when they have this disease. So what we will probably have to be taking is a very pragmatic approach to this. So if we understand there are people who are not following those rules, who are not keeping people off when they're sick, or not paying staff to be off when they're sick, or people who are not actually who are moving between services, because the provider has not taken the right actions to make sure that they have other plans in place, because they haven't really thought through what is going to happen over the next few months, and they haven't used the resources that are available to them in the right way, then of course we'll need to look at that and see whether somebody has broken the regulation. But we know how difficult it is. We know how hard it is for our staff, and we also know how many of our staff are dependent on having more than one job to be able to actually kind of keep the food on the table and keep their families together. So there has to be a real effort from all of us to think about how best do we make sure that people are protected, and how do we use our staff to the best ability within the law. But till it comes through, it's a bit difficult for us to say exactly what we're going to be able to do.
Great, thanks, Debbie. I think we maybe got time for one more question, and then we'll try to pick up the rest in the next Q&A session. So there's just a question about the length of our transitional approach, whether it's going to be lasting to April next year or potentially longer.
So I think that's the current plan. Kate may have some more to say on that. So I might hand back to Kate at this point, so seeing she's going to go back into the next round anyway.
Thanks, Debbie. So I'll start talking. Oh, yeah, there you go. You got me. So certainly the intention is that everything we do kind of builds on what we've developed so far. And again, like you, no doubt, all the different ways of working that you've tested out during COVID, there is a real commitment that we want to keep what works going forward as well. So the ability we have tech-wise around capturing some of these regulatory monitoring conversations, our learning from our home care pilot, and I've seen some of your comments about what you also think can be achieved virtually rather than in person. All of that will need to be bundled up into how we work going forward. So that does flow on to what I'm going to talk about now, which is the four proposed pillars of our new strategy. So this is where you have a real chance to influence. So we are in the conversation stage of a strategy that we'll be consulting on formally in January. But there are some key questions I've got for you as we go that your feedback would absolutely, this is a window to do some real influencing as well. So I'm going to talk about people, smart, safe and improved. So if we go to the first one. So we know that people's experiences of people's outcomes are very much influenced by the way that health and social care providers work together to ensure that they get good joined up care. And we also know people's experiences and outcomes are very much influenced by their ability to access the right care in the right place at the right time with the right professional supporting them. So we want to increasingly regulate providers through the lens of the person receiving health and social care. So we want to focus on whether people feel listened to, whether that people have access to the information they need at the right time to help them make decisions. And we want to play an increasing role in talking about health inequalities and not just looking at what people's experiences are when they access services and the quality of those services, but also what their experience is in getting access to the right care at the right time. So when I think about this one, I think about Think Local Act Personals, Making It Real I statements, where there's a set of statements written by people who use services who talk about their expectations about how care should be wrapped around them, where people should have a really good understanding of what their needs are, and it should be coordinated well. And this is where we would like to regulate much more through the lens of what it's like to experience accessing health and social care. So if we move on to smart, please. So smart is about how we can regulate in a way that's much more flexible and enables us to use the right regulatory intervention depending on the service or the scenario. So we've been talking about that a bit so far. So things such as our new IPC tool, things such as the functionality we have around having these structured monitoring conversations with you all, our ability to go out and do focused and targeted inspections that are narrower but still enable us to look across the 5 key lines of inquiry. We want to build on that, so we want to make sure that we collect information digitally, that we don't, we're not another organisation asking you to share the same information you've already given your local authority or your clinical commissioning group. We want to make sure we collect the information once and that we make it available so that people can use it. We want to move away from inspections that are based on previous ratings to much more flexible inspections that happen when the risk or the need warrants it. We want to make sure that we're proportionate when we go out. So we want to ensure that when we do go out and visit a service, we're doing what we absolutely need to do in person, and everything else we do prior to visiting or after. And we want to be really focused when we come out and spend time with you in your service. And we want to be flexible and responsive. So we want to be able to respond to intelligence when it comes in and go out and respond in a way that's proportionate. So that's what we're thinking about SMART. If we move on to SAFE. So safety is a language I think that gets used maybe a bit more in health than it does in social care. So so in health they often talk about a zero tolerance around safe, never events, etc. Zero avoidable harm. When I think about safety in social care, so forgive me if you've heard me say this before, but in health services, they have a national reporting mechanism when it comes to reporting medication errors. And on average, about 237 million meds errors are reported each year in health services. We don't have an equivalent mechanism in social care, but we do, until COVID, we had our PIR, our provider information return. And when we look at the last few years on our provider information returns, approximately 50% of providers, social care providers, say that they've had no medication errors. And the reason why I mention that is there's something for me about recognising when an error has occurred, naming it, having a reporting mechanism to capture it, and then most importantly learning what were the components that contributed to it. How do we take that learning so that it doesn't happen again within the service, but also much wider. So this is about how we can absolutely move the dial more on safety, but also when we talk about safety, and I think about safety in social care, for me it's really important that it isn't a paternalistic conversation. It isn't, professional knows best person receiving care, but it's much more how we have a partnership conversation about safety and risk, so that people who receive services also have ownership about what risk-based decisions they want to take as well, depending on their capacity. So there's a bit about safety. And then if we move on to improve, so this is one where I would particularly welcome your comments and questions. So and this is one where people are quite split on our opinion on this. So my opinion on this is that everyone in the country should have access to good or outstanding social care. And if you happen to be a provider in an area where you've got a fabulous local authority quality monitoring team, or you've got a great community health offer from your local health provider, or you're part of a massive organisation that has its own quality monitoring function or internal audit, there may be many places for you to go to get support to improve. But I remember back to meeting a new registered manager of a service that requires improvement, and she said to me, where do I go? Where do I go to improve? And I would really like to be in a scenario where, regardless of where you are in the country, regardless of what your local authority or CCG offer is, regardless of whether you're a big provider or a teeny home care organisation supporting 20 people, that you all have access to the right quality improvement support. And if that is something that you recognise, so firstly, is that something that you recognise, that there isn't that consistent improvement offer in social care, then my question to you is, might the regulator have a role in being the convener of that improvement offer? So what I mean by that is, because we have that visibility of all social care providers, registered social care providers in the country, and because we also, in a very small number of circumstances, so I think most providers want to improve and would snap the chance up to have support in that area. for most providers, I think inspectors could play more of a coaching role. So I think inspectors could do more of sitting alongside a registered manager, signposting, coaching, supporting, encouraging their improvement. I think in a small number of scenarios where the provider is unable or unwilling to engage, we might need to have more of our traditional regulator approach and style. But I'm interested in the role of inspector as coach, but also as CQC moving into a convener role where we map out the improvement offer around the country, we call out where their gaps are, but also maybe we help bring together a kind of package of support for those providers that don't sit within that infrastructure of help for them. So that's my thinking on it. But I know many people don't think that's, many people have a different opinion on that. So what do you think? What do you think of the idea that inspectors should be have more of a coaching style? Do you think that's a complete blurring of the role and you should leave well alone and you should have a very formal regulatory role with your inspector and it shouldn't be any more? So that's my first question. And then my second one is, do you think the regulator is do you think there is a gap when it comes to a coordinated improvement offer for social care providers? And if so, what role do you think the regulator should have in addressing that? So I'm going to quickly scroll down and see what, hopefully you're starting to respond to some of those questions, and we'll come back to that in a minute while I just send my last couple of slides. So what we're going to do next is we're going to carry on rolling out our transitional approach. We're going to formally consult on our strategy in January, and we're going to take all our learning from the summer and before into our way of working going forward. And next one, please, Steph. And then following the consultation, we will implement our new strategy from May, but there will be many more occasions for you to contribute and get involved. So the next slide just reminds you what you probably already know. If we go on one more slide, Steph. So there are many ways for you to get involved. We've got our digital platform called Citizens Lab, where you can have a read of our strategy discussion document. Hopefully many of you get our provider bulletins and blogs, and you can follow me or the CQC Twitter account as well for information. And we've recently started putting out podcasts as well, so many ways for you to get involved. So I'm going to pause, scoop my eyes over some of your comments and hand over to Sam and just see whether there are any reactions to what I said around a potential new strategy for CQC.
Thanks, Kate. Yes, we've got some really interesting comments on those strategy themes. On some of the improvement questions you posed. So we've got a bit of a general question about whether we've given any thought to how we'll link in with some of the existing organisations that already work in the improvement space, and also a bit of a suggestion that we could do more work publishing best practice and guides to how to deliver best practice, and a bit of a reference to Ofsted, who some people think do this quite well.
Okay, interesting. So I've had a couple of conversations about this idea before, and I always think, when you try and co-produce something in a genuine way, it means you often have quite a blank piece of paper when you start talking to people about it. So the great thing is there's a chance to shape it together. The flip side is there are a whole load of questions you don't have the answers to. So so let me be really clear that this isn't we haven't landed in a place on this, and this is why hearing what you think about this is really important. So important questions like, there's a lot of support available out there already. Don't duplicate, and how would you dovetail into it? I don't know. I don't know the answer to that, but I would be really keen to hear your thoughts as well. I'm looking, Sam. There's quite a lot of positive responses to the idea of inspectors having more of a coaching style.
There is, Kate, and I think a really good reference that providers would really appreciate a closer relationship with inspectors and more regular contact and more regular support in that space, which is interesting to see. Yeah,
and I noticed earlier, Katie commented earlier that her inspector changed. She wasn't informed about it, and she's got someone new. And there, I think there's a balance we need to strike where there's something for me about the inspector having a relationship with the registered manager, understanding the context of your service, the model of care, so that when they come in, they're not coming in cold, and you don't have to explain from scratch why, you know, a supported living service looks like this rather than that. But then there's also the balance of, I do think there needs to be some degree of rotation so that it keeps quite fresh. But I would definitely like to see a longer period of time for inspectors and providers to establish those relationships. And I think we do. I think it's working really well in some parts for some people, and that's not the same experience for other providers. So again, if you know how long, you know, do you think you should know your inspector, you know, pick up the phone, have those regular conversations with them? How often do you think they should change and refresh? Do you have a view on that as well? That would be great.
Thanks, Kate. We've looking at one of the other strategy themes. We've also got quite a few questions about any thinking we've done about our change to how we inspect and rate services in the future. So questions about our inspection frequency, whether that will change, whether our key questions will change, or whether we'll look to rate services in a different way, maybe not relying on inspections, but relying on other types of activity.
Great. So again, absolutely all up for discussion. I think what I would acknowledge is the ratings are like a currency that makes sense to the population. I think we've I think they're really established, and I think people know what they mean, and there's like a real helpful simplicity to it. So I think there is a value in the current currency of ratings. However, I think many of you would say to me, if this was a two-way conversation, that so I've heard many providers say, you're good rating. So a provider who, you know, arguably, you know, just gets into the goods end of the category to the provider that's, you know, not quite hit outstanding, but is absolutely, you know, delivering really strongly against each of the key lines of inquiry. So I certainly heard providers say that would it make sense to break out some of these ratings is one thing. Other things that you might want to think about. So as none of this, and I'm not giving any sort of inside scoop, this is all things that are up for discussions. So how do you make your ratings more responsive to changes in intelligence coming in? Could you re-rate a service without physically going out there? Could you re-rate a service based on a collection of intelligence from Give Feedback on Care? How much emphasis should we place on local authority quality monitoring visits, you know, and the product of that? How much should we place on intelligence that comes from other sources? What would it look like if a rating wasn't linked to an inspection? Is a question. What would it look like if you kept the 4 ratings, but maybe there was a scale from 1 to 100, where 1 to 25 was inadequate, you know, 26 to 50 requires improvement, etc. And what if you could move up and down within those ratings depending on intelligence? And what if that was mainly more information for you as a kind of benchmarking improvement tool? So instead of maybe confusing something that works for the public, but maybe if you've got, you know, you've got a good rating to the public, but actually you know that your good rating is 72 and you're just a hair's breadth of outstanding, and you could look across to other services and see. So I think there's a question about, might there be value in getting more granular with our ratings to help drive improvement for providers, but maybe not necessarily make a really complex system that is confusing for the public to understand? But again, I think there is value to ratings. I just think the challenge to us is, how do we keep the ratings as live as possible? And one way of doing that might be that your rating could change without an inspection. I don't know what I think about that. Would love to know your thoughts. And then the other is, how can you use ratings to drive improvement by maybe giving more of a breakdown of, you know, if I'm a registered manager of a good service, well, how good am I, and how do I get myself up? You know, how do I improve the quality of care by looking at other providers that are, you know, maybe slightly ahead or doing something different or better? So definitely all up for discussion as well. And now is the time for you to, gosh, I wish I could read the 483 comments that are sitting in the chat, and we will look at them all as well. But yeah, really up for hearing your thoughts about ratings.
Thanks, Kate. And there's really good discussion going on in the chat about our improvement offer, about CQC as coaches and mentors, and publishing best practice. Loads of good reflections about which one of those is the best approach, or both of them. And just as you said, we'll be capturing all this and making sure it is reflected in our thinking going forward.
Yeah.
There's also been some questions about collecting information from providers. So a bit of reflection that there's often loads of requests from different people for information that aren't always joined up, and also our own information collection mechanisms aren't always the easiest for providers to use. And I wonder if we want to say something about that aspect of the strategy.
Yeah, so we want to do this a lot better. We want to do this a lot better to ease the pressure on you with needing to complete multiple information returns, and we were particularly attuned into that at the beginning of the pandemic, where you have to provide a lot of information anyway, but put us in the middle of a pandemic, and the risk of those information requests, the frequency and the detail was significant. We obviously paused the provider information return at the start of the pandemic while we introduced our home care tracker, and the capacity tracker was launched within the NHS. There are active conversations at the moment that some of your trade associations and us are involved with the department as well, about what is the best mechanism for bringing all that information together, who should have access to it, how does it drive action that's needed on the back of it. So if there's a whole lot of intelligence saying that there's a problem in this part of the country, or there's an issue with testing, or there's an issue with this bit of PPE, how do all those different sources come together in one place? I think there have been some improvements on that, but I think we all would like to do better on that, and there are ambitions and conversations that are underway that I probably would need to come back to you all on about in the nearest future to update you on, including what our thinking is around PIR, so our provider information return. So there is definitely some information that we're not capturing because we're not getting those back, and we have been talking a lot in CQC prior to the pandemic and during about closed cultures, and about risks for people in services where closed cultures can develop. And actually our provider information return is a really important source for us, about giving us information about staff turnover, registered manager, all that sort of stuff. So we are missing something a little at the moment in the absence of it, but we're really conscious about how and when and what it would look like if we were to reintroduce that back in. So if I can come back to you hopefully in the next month or two about that, that would be great.
Thanks, Kate. That's great. And there's loads of interesting comments about more responsive ratings, or rating in different ways, which is really interesting to see. Yeah. We've also had some questions about kind of potential changes to the scope of our activity in the future. So some questions about whether we'll look more at systems or commissioning, or maybe even that we would take on more of a campaigning or advocating role on behalf of providers.
Okay, so let me do that last one first. So I think that there are, and I know there are some on this call, very strong trade associations who do a really good job at advocating on behalf of social care. I think we absolutely have a role in terms of using the intelligence we have about what's happening in health and social care to call for things when we see them, as that kind of independent voice as well. But I think there are already some really fantastic advocating organisations that do advocating really well. I think sometimes our challenge in social care is to be as consistent as we possibly can with some of the key things we're calling for. So in our state of care report that we published about 2 weeks ago, we, along with many of you on many of occasions, called for that long-term sustainable funding solution for social care and a new deal for our social care workforce. And I think the challenge to us as a very dispersed sector, without a single kind of figurehead, which I think is the right thing for us, it's how we collectively use every opportunity we have to bang the same drum about the same messages if we have agreement on them. So that's one thing. Regulating systems. So yes, I think there definitely in our new strategy, there will be we will continue to hold individual providers to account for the safety and quality of their services, but I strongly suspect there'll be a stronger emphasis on how well do you as a provider work with your system, your other providers in the system, to ensure that people get high quality joined up care. So for example, if you are a big acute hospital, can you be good or outstanding if when you look outside your doors all your social care providers are falling over and are poorly rated and So something that places an increasing emphasis on providers owning their bit really well, but also thinking about how as a home care provider, you're working with the GP, you're working with, with the hospital, etc., to ensure that the people you support get good joined up care. And I know often it's particularly hard for social care providers to do that because there's so many of you, and often the scale isn't there. But if we also place an equal emphasis on a big acute hospital trust or a GP practice or a dentist to say, okay, dentist, you're serving the patients that come into your surgery really well, but how effectively are you getting out and going into a care home to deliver oral health assessments? So yes, I think there'll be a lot more on systems. And finally, on commissioning, I will say it because I believe it as well. So Jane Townsend from UKHCA says often, and one of you has put it in the chat that I've seen, that we judge home care providers on the quality of the service they're providing. But home care providers in particular say that their ability to deliver high quality care is impacted by how they are commissioned, whether it's time and task, whether they've got travel covered, etc. So I absolutely believe commissioning plays, how services are designed and purchased absolutely plays a key role in the quality that's being provided. We don't have the regulatory power to do that currently. I don't know whether there's an appetite for that to change. You all are a loud, strong audience that might have a view and might want to talk collectively about that as well. But certainly through our work with systems, when we did our system reviews a couple of years ago, we were able to talk, because we had special powers issued to us for that, about the impact of commissioning on people's experiences of how health and social care was delivered. It's 2 o'clock and I've probably talked far too fast anyway for the last hour. I'm going to draw it to a close now and say a massive thank you. I can't get over how many comments you've put there. Would be really keen to hear how you found the chats, the hour. Was it a good use of your time? What could we do better next time? You might tell me to speak slower, which is a challenge I'd probably struggle with, but happy to hear that feedback as well. And keep talking to us about our strategy. There is a real window to influence how we are changing, because we're changing rapidly, just like you are. So tell us about inspectors as coaches, tell us about ratings, tell us about commissioning, get involved and tell us what you think should be in that strategy. Massive thank you to you and your staff, and I hope the next few weeks and months are as as bearable as they can be, and keep doing the fab job you all are out there. Many thanks, and we'll finish there. Thank you.